Colonoscopy workshop, and it's a pleasure to meet you all, and welcome to SIAG. And our esteemed faculty is also here, Dr. Professor Saad Niaz and Paul Heyman from the UK, and Dr. Shanil, who's a co-director of the course. Sir, we are short one candidate. He's on his way, and our observers are also coming. So would everybody like to introduce themselves before we start? No, Ajit is bringing it. He's doing it. Just give me 2 minutes.
بسم الله الرحمن الرحيم قل هو الله أحد الله الصمد لم يلد ولم يولد ولم يكن له كفوا أحد صدق الله العظيم.
So now if Dr. Saad would like to say a few words in the introduction, then we can begin the course.
Despite of giving enough time, we still okay. That's something that happened. Bismillah ar-Rahman ar-Rahim. Thank you. I'll just give you a brief introduction of our journey. I think it's important for you all to know because you are at the start of your career, and hopefully, inshallah, you'll go and reach higher. So we started in civil hospital here in 2006, and that time we were given some endoscopy equipment and fluoroscopy, and there was no public sector facility providing advanced endoscopy or quality endoscopy in the public sector. Even the private sector was very, very small. This is way back in 2006. So we started there, and then I was trained in UK, and I came here. At that time, they had just started these courses, hands-on courses, and I was fortunate enough to see one of the first few courses, and because it was being held in one of the units I was working. And since I came back, after seeing a lot of people doing colonoscopy, I thought, this course is really something that we need in Pakistan. And a very dear friend of mine, a colleague in UK, Dr. Waqar Ahmed, we had a chat, and he said, we need to start our courses, Waqar, because there's a real need here in Pakistan. And then as we literally struck gold because we met, Waqar met a gentleman called Paul Hagen, and he actually on a course, and he asked Paul, we wanted to do this course, would you be kind enough to come to Pakistan? And Paul agreed. So Waqar called me and says, look, we've got the team, let's do our first course. This was way back in 2010, if I'm not wrong. So I still remember, Paul came to Karachi. I had never seen him, I had never met him, he didn't know who I was. And so we first time met, and I said, look, on a Sunday, like today, I said, let me just take you and show you where we are going to do the course. And so I brought him to civil hospital. And he told me, he says, when after seeing the whole unit inside, the equipment and everything was good, but we had 2 rooms and maybe half a room for cleaning and all. So he came, he said, after we finished the course, he told me, he says, when you took me first day, I said, oh my God, what have I got myself into? And I don't even know if they have scopes. I don't even know if their scopes have lights. Because when you enter civil hospital, And in those days, probably it was worse than what it is today. So 2010 हमने फिर course we started, and we did our first course, and we got a very positive feedback. There's a lot of contentment here as well. And from there on, this is our 14th course. And I think the trainees here who've come here, who get an opportunity to do this, not because I'm involved in it, but really, it's better than any course there is hands-on. I can very proudly say it's as good as any course anywhere in the world. And thanks to Paul, thanks to a lot of other people behind this whole effort that you see, Saeed Quraishi, Sajda, Shahryar, and now the team has grown. And last year, we inaugurated this facility. This facility has 4 endoscopy suites, 1 ESWL suite, and we are almost doing everything that is done anywhere else in the world. And both in terms of, mostly we do advanced cases or therapeutic cases, but we also do diagnostic cases. We now have a good team today. So we have Dr. Shanil Kadir, who's come from UK and is working here in Karachi for some years now. Dr. Afzal Haqqi, who's been with me for a very long time. And both these gentlemen will be part of the faculty. They've both gone through the trainer's course, because one thing is learning colonoscopy, the other thing is teaching colonoscopy. So you need to know how to teach, right? This concept of do one, see one, and then teach one was something that was there for a long time. Someone would give you a scope and say, okay, play with it. But now you don't have to do that. Actually, everything is broken for you, everything is made easy, everything is, you have a concept for most things. So that's what, that's been our journey. And today, alhamdulillah, I think we are very, very happy to have a very, very good team. Dr. Nawal was here, Dr. Asim is here, B. Nasir. So we're actually developing into a good team. Other people will join us during the day as we move on. What is the course about? Why I feel it's good? Because what we have learned over the last 5 years, we actually tell you in 3 days. Okay, so that's number one. You have more than one ways of doing the same thing, and it will be for you to see there are certain principles where you need to understand there's only one way. There may be others where my preference may be something else and Paul's may be something else, or Shanil. And so you'll get an idea. You'll get to know what is right. You'll get to know what is wrong, what must not be done in colonoscopy. And that, I think, is very important. Because if your foundation is good, then you can develop on it and you will not make mistakes, and gradually you will become as good as anybody. I can tell you I do almost everything in endoscopy, and colonoscopy is one of the most challenging procedures. It's more challenging than EUS or ERCP for me, because it's so unpredictable. And it's a regular procedure, routine procedure for everybody. So it's not, you have a tube and you have a scope and somehow or the other you'll reach the cecum. Yes, you will. But there is a way to reach. And that's what this whole thing is. It's about safety, quality, okay, concepts, okay, solid foundation. That's what you will hopefully get from this course. What we quickly do is we introduce ourselves. I'll leave Paul to the end. part introduction I've given. So we'll start first with the candidates, and then as we go on, we'll just introduce ourselves. So where's the mic? Here it is. So what I want you to tell me is, आप कहाँ से हो? ठीक है, which hospital? Number one. Number two, we want to know, are you doing colonoscopies? Two. Number three, what do you think you find difficult in doing your colonoscopies, right? What is? Write it down on there. Okay, ठीक. And what is your objective? What is your goal coming to this course? So if you can just tell us quickly about you and just tell us.
Thank you, sir. My name is Dr. Talab Rishi. I am a consultant gastroenterologist. I am working in different hospitals of Karachi. I am Sakhar based. So my prime objective of attending this course is to learn how to de-loop and shorter intubation time, and particularly in those patients who are IBS-C patients. I found a bit difficult.
Should we be doing colonoscopy in IBS-C patients?
No, sir. No.
So we are already making it difficult by picking up the wrong patient, right?
Yeah.
But sometimes we do, and there would be reasons for it, and I'm sure you know that. So loop is one issue, and duration of reaching the cecal. Okay, and so those are the two objectives you've come here for. Great. How many colonoscopies have you done?
Sir, after being a consultant, I have done 10 colonoscopies.
10?
10.
Okay, and before that?
So before that, I cannot tell you the exact number, but like around 30 or 40.
Okay. And you've done your FCPS gastro?
Yes, sir.
Thank you, sir. My name is Dr. Mudassar Ashraf. I have done my FCPS medicine in 2020 from Lahore General Hospital. Now currently working. जी मेरा नाम सर डॉक्टर मुदस्सर अशरफ है. I had my FCPS medicine in 2020 in Lahore General Hospital, Professor Gas Naveed Tayyib unit. Then currently now I am in Jinnah Hospital doing second fellowship gastroenterology, end of second year training under Professor Shahid Sarwar Sahab. I am Shahid Sarwar Sahab, and I have started doing colonoscopy since 1 year almost now, and I have done almost 15 cases, almost 1.5 years. So my problem is doing crossing sigmoid, maneuvering acute bends, scope shortening, and managing the loops, and how to deal with the patient with poor perforation, gut perforation. These are few initial things that I counter daily on a basis. Thank you. Thank you.
Assalamualaikum sir, I am Sultan Ahmed. I have passed my FCPS in 2022 and I am currently working, yes sir, gastroenterology. And I am currently working at Nishra Hospital, Multan. And sir, yes sir. Sir, my aim is to first to do a complete colonoscopy. And secondly sir, there are multiple issues, as you know, that crossing the acute bends and avoiding the loops, and finally island intubation. Sir, after passing my FCPS around 10 to 12, and before I am unable to remember. Yeah, sir, almost 50, sir.
Assalamu alaikum and good morning to all. Dr. Muhammad Nazir from Peshawar Northwest General Hospital and Research Center, working as an assistant professor of gastroenterology. I have done almost 100 to 150 colonoscopies. My basic aim of coming to this workshop is just to know about shortening of this shorten the colonoscopy loop, and plus de-looping, and sometime in crossing the retro-sigmoid junction. That's what, and also ileal intubation as well. So these are my reason to coming to this workshop, sir.
One thing I wanted to ask you, sorry, what sedation are you using for colonoscopy? Kya sedation? What's the dominant? How much dominant do you use? Average? 5 milligrams. And do you use anything else like pins or how much? So 5 milligrams of domicum and 2 to 3 milligrams of pins.
These are basically how we 3 to 4 milligrams of once widely
Sir, 5-10 milligrams and 2-3 times
5 to 10 milligrams of midazolam. 5 to 10 milligrams of midazolam, right? And 2 to 3 milligrams of it.
Sir, 2-3 times
mostly we can do the special diet.
We use the midazolam of 2.5 to 3 milligram, not more than 3 milligram. That is our practice. And nalbuphine, nalbuphine we use not more than 5 milligram.
So you have a cutoff where you say 3 milligrams of midazolam
and 5 milligram
and 5 milligrams of pins. Okay.
This is our
Who's the next hands-on? One of you? Yeah. आप इंट्रोड्यूस भी करा दें. Where are you from?
Assalamu alaikum. It's me, Dr. Ria, PGY3 at the Chandka Teaching Hospital under supervision of Dr. Aliadar Baloch.
Okay, you're with Aliadar.
Ji. So my objective is to how to deloop because I have difficulty while performing the colonoscopy. Mostly I found difficulty by crossing the rectosigmoid junction or in the transverse colon.
Okay. And how many colonoscopies have you done?
I did one full colonoscopy, while other on looping I left.
You give it to the
transverse
person
colon.
who's next.
Ji, ji.
Okay. So you have very little experience, right? And how much sedation is used in your department?
5 milligram midazolam and 2 to 3 milligram kins.
Okay. How many observers do we have? You, okay. Please introduce yourself.
Assalamu alaikum. I am Dr. Murk from Chandka Medical College.
Okay.
I am PGY3 under supervision of Dr. Ali Adar. I find difficulty in navigating through the loops or bends, and patient becomes uncomfortable when I am performing the procedure. So I also find difficulty in crossing the rectosigmoid junction, and I have not crossed beyond it.
You
So
haven't
I am
crossed
here
yet.
to, yeah, I am here to learn each and everything
Okay.
about the colonoscopy. Yeah.
Okay, fantastic. What I will do is I'll pass on to now to Paul.
Good morning, everyone. I may have missed, but can you identify who's surgeons and who's physicians?
Is there a surgeon here? They're all gastroenterologists.
All gastro.
There's one, I think, observer who's going to be surgeon, who's a surgical trainee. But the rest, all of them are actually either postgraduates or in training, GI training centers.
The biggest, most important thing to get out of this course is to actually don't feel that you can't ask a question. There is no silly question. No one is going to think anything of you if you don't know something. If you feel that you don't know something you can't approach, then there is always going to be someone else that you can identify in the team and the faculty. You can always approach them. The biggest enemy on this course for you is your own self. You're going to be very withdrawn. You're not going to want to actually come forward. This is a course that you own. This is a course that you've paid for. This is something, if you really desire and you want to have, you want to get the most out of, you must just ask any questions. Get involved. Don't feel that you can't ask. Do not feel that you can't enjoy yourself. If you don't enjoy what you do, you're not going to do it to the best of your ability. There's going to be times when you're going to feel a little bit down, and that's when the faculty will bring you up. There are going to be times when you're so elated, and they're going to be elated with you. So just enjoy yourself. Get the most out of the course. Doesn't matter if you're Saad and you see him right up there. Doesn't matter if you're me and you see me right down here. Doesn't matter who you are, where you are in the team. Just enjoy yourself. Get the most out of it. With regard to your abilities, numbers. What's the importance of numbers? Experience. So if I've done 100, am I well experienced? Probably. So if I've done 50,000, how experienced am I? I must have a lot of time on my hands. So the thing is that numbers, in my opinion, mean absolutely nothing. What numbers actually mean is that you're able to actually put your hand on a scope and someone's allowed you to have 50 attempts at doing something. If these 50 attempts, what you should have been getting by now is actually an understanding of how to actually manipulate the scope a little bit. When you start out and you're finding difficult to get out to the rectosigmoid, you need to be looking at how you are feeling on the scope, touching the wheels and all these type. Numbers mean nothing. I've seen a fella who did 10 and he was slow, but he could get to the terminal ileum. 10. There was a lady on the course last time that we were here. She was amazing and she had done flatness. Remember, she was amazing. Absolutely slow and steady wins the race. Now the next thing and final thing really, I'll shut up because I do talk a lot. The most important thing is that you'll be given a certain amount of time. In any learning experience, there is an optimum amount of time that you gain the most learning and opportunity to learn. If you spend too long a time and getting frustrated, then that takes away from the learning experience. So we will be actually looking at time as part of this. So take away, what are your objectives? A lot of people come with the objective of reaching the terminal ileum in every case. That's a false target. The best that you need to be getting out of it is, am I able to manipulate the scope in as pain-free, discomfort-free environment? Am I getting advanced? Am I getting a better understanding of what I am doing? If you can do that, you will come away a much better person, and you'll find that after a few, you will actually be able to advance the scope quite easily. But get the most out of the faculty. There's a lot of people here in this room that have got a lot of experience who actually know what they're doing. If you feel that you're having difficulties, don't feel that you can't approach someone. And you will be appointed a member from the faculty to actually support you over the next 3 days. And at the end of the 3 days, we will sit down with you, that person and Saad will sit down with you and discuss how you can go from here with your development and what the next steps would be to help you improve even further. Okay? So there is a distinct plan. It's not just about coming to a course and seeing something and doing something. It's about having a plan for yourselves.
So this is not an observational course. This is actually a hands-on course. So we will actually, what you have highlighted, we will actually address everything. You will get minimum 4, and our aim would be to give you 5 hands-on colonoscopies during in the next 3 days. But you will also see another 20 being taught, which I think is not active learning hands-on, but there's a lot of learning in that. So what Paul is trying to tell you is that we are here, all of us, and let me tell you one more thing, I have to say this. No one here is getting any money out of this course. This is all being done pro bono, okay, by everybody. So Paul comes here, we don't pay him anything. He doesn't even, this is his, 14th time for this course plus workshops. And the whole objective is to teach you. We are here on a Sunday and the next 2 days just to teach you. And what Paul has said, and I will re-emphasize, is that none of us are professors. So please relax. जो सवाल है बहुत silly लग रहा हो आपको, ask. You'll learn the most from that. नहीं आता, doesn't matter. ठीक है? One thing about reaching in good time. There is reaching in good time. I don't know what that good time may be. It may be different for Paul, different for me. It's about reaching safe, pain-free. That's what matters, and in the correct way. Doesn't matter whether somebody else is doing it 5 minutes earlier, so what here, you know. But it's about reaching and about patient safety and comfort. Colonoscopy should not be painful. Okay, it can be uncomfortable, but that too for a very short period. But it should not be painful in at least 95 out of 100 cases. If you have 5 cases that that you have pain, then I think that's something that a lot of people, you pick up a wrong patient, you'll have that. Shanil, आप भी अपने, I have introduced Shanil already, and Afzal थोड़ा सा अपने बारे में बता देंगे.
Assalamualaikum. I think few of you know me. I already introduced before you guys.
अच्छा, okay.
So I'm a gastroenterologist here at SEAG. I was trained in the UK, so I moved to Pakistan 4-5 years ago, and I've been with this unit since last year, and before that, when we had the smaller unit. I think this is my second colonoscopy course. Last year we did first one, and this is the second one
in this setup.
So I think the important thing, as Paul and Dr. Saad said, was that we want you to enjoy the course. No, this is not an exam कि जी आप कर पा रहे हैं कि नहीं कर पा रहे हैं, या मैंने तो सीकम ही रीच नहीं किया, मैंने तो सिर्फ रेक्टोसिग्मॉइड तक पहुंच गया. It is not about that. It is about learning how to do a safe colonoscopy. As one of the candidates mentioned, I want to do a comfortable colonoscopy. जो मेरा patient जो है वो comfortable हो, ठीक है, उसको भी पेन नहीं हो और मैं भी comfortable हूँ, मुझे भी स्ट्रेस नहीं हो कि यार मैं कोलोनोस्कोपी कर रहा हूँ तो मुझे पहुँच ही नहीं पा रहा सीकम में और इतना टाइम हो गया और पेशेंट भी जो है वो डिस्कम्फर्ट हो रहा है. तो फर्स्ट थिंग, डोंट हेजिटेट टू आस्क एनी क्वेश्चन. Second thing, just feel comfortable, even if you don't reach CECUM, that's why we are here to teach you. We are here to teach you how to do a safe and proper colonoscopy. We don't expect कि आप पहला प्रोसीजर करेंगे और आप जो है वो TI में हमें पहुंच के दिखा देंगे ना, तो फिर कोर्स का फ़ायदा ही नहीं है, तो आपको वैसे ही सब कुछ आता है, ठीक है. तो that's not the aim. And if you get stuck, that's where we want you to ask us. And the fourth important, so सबसे important होता है कि when you are stuck anywhere, just stop. The general trend is कि if I am stuck anywhere, I want to proceed. Why am I stuck? I don't accept that. Why am I stuck? I just want to proceed. So when you are stuck somewhere, that's the point to stop and reassess yourself. What am I doing wrong and how can I do it differently? Thank you.
अस्सलामुअलैकुम. I'm Dr. Afzal Haqqi, I'm at Veterinary Hospital. और Dr. Shanil ने कहा कि procedure should be pain-free and painless. That's very important. Actually, this is very user-friendly course. ये हम सब सीखना है, आप भी और हम भी. और मैं डॉक्टर साद के साथ ऑलमोस्ट 15 साल से अटैच हूँ, सिंस 2010. जो कुछ सीखा है आने के बाद ही सीखा और अभी भी सीख ही रहे हैं, और हम तब इंशाल्लाह सीख के जाएंगे यहाँ से इंशाल्लाह ताला. That's very user-friendly course.
Just come and you will be penalized for that. All those people who come late will have to pay. Please go ahead and introduce yourself.
I'm Dr. Shamil Nazir from Ziauddin Hospital, GI resident of final year. Just I come here for observation. Almost 100. Almost 100. Yes, sir. Before there was difficulty reaching rectosigmoid junction, but after doing more than 50, then I just feel difficulty reaching cecum after the apex flexure. There I feel some difficulty. Yeah, just to learn that reducing loops and making colonoscopy more comfortable for the patient and making it pain-free. So that is the objective of coming to this course.
Thank you, sir. Dr. Asim here. I am part of SIAC team working here since it's on inauguration. All I can say is looking forward to an amazing course for everyone.
And so, again, I'm Novel Zakaria. Sorry. Yeah, I'm Novel Zakaria. So I joined SIAG last year as well, and it's been a wonderful experience working here. And I hope you guys have a wonderful time in the course as well, and that you learn everything that we learned when we attended this course last year. That's when we realized that there are actually, as Dr. Saad mentioned, concepts and foundations to colonoscopy. And I'll just mention one thing, that when I was a trainee, during my training in gastro, I fumbled with colonoscopies a lot. I struggled with them even towards the end. I would say it's either going to be a hit or a miss. I can make it there. The patient might be comfortable. But when I came over here, I had the faculty, especially during this workshop, teach me and tell me things that I didn't actually know I had, that were going to be this useful. As in, just talk to yourself about how you're moving the scope, or just speak with the team if you feel the patient's uncomfortable. So this is a lot of take-home messages that you can grab in this course just in these 3 days. So I hope this experience is as good for you. Thank you.
What we did before was, we used to have, when we were changing it this time for the first time, we want the feedback. We used to have lectures on different things, indications, complications, sedation, safety, management of complications. And then we had a discussion. We thought, most of you have done your CPOs when they come here, most of the candidates. I thought we were actually, the lecture wasn't really something that was needed here. What was needed was a discussion. So we have a free period, some time now, before we actually go on and start with the actual demonstration. I think it's important that we touch something. So I'll just float questions like we did before. And you don't hesitate. Even if you give a wrong answer, doesn't matter. You are at a stage where you can. Or to me, even at my stage, if I do something, if I give you a wrong answer, then I don't know something. I'm not supposed to know everything. I can't. I'm not Einstein. So we'll start first. We all agree here that colonoscopy, the main target of doing a colonoscopy should be patient safety, patient comfort, complete. The importance is more of withdrawal time than of reaching. I've had people who are experts who will claim that, I can reach the cecum in 2 minutes. Very good. I'm not interested in how quick you reach. I'm interested in how much time you put when you're coming out. There is a reason why you're doing colonoscopy. You want to find something. So there is safety, comfort, and then obviously completion. But there is quality. And quality would depend on certain factors. In some of them I mentioned before, the other is picking up your polyps, picking up your lesions, picking up, reporting, picking up and also reporting. And then also dealing with what you've seen. Is it something that you can do? Is it something that you shouldn't be doing, sending it to Paul or Shanil? Or, okay, fine, I have seen Paul do some big polyps. I think I can take them out. No problem. I'll put a snare around and take it out. So We'll start with the first thing is indications. So what would be clear indication for colonoscopy, Dr. Tala, for you? Bleeding per rectum, okay. So if somebody, let's discussion sake, if somebody had bleeding PR, she or he is 19 years, what options do we have? No, what options do we have in terms of offering the procedures? Remember, this patient is young and has got blood in the stool, right? That's all. Everything else is good. So what I'm coming to you, what I'm trying to highlight here is you have a procedure called flexible sigmoidoscopy, right? So you don't have to do a full colonoscopy because some patients would come and say, you know what, prep is no. Have you ever taken a prep? Anyone? I have. I've taken it twice already. And Nasir has. Even the prep that we give Paul is not that bad. But I know what they do there is difficult. Our prep is 24 hours. And so what I'm trying to say, highlight here or emphasize is that not everybody needs a full, complete colonoscopy. Okay? So you can get away with somebody is just bleeding PR, young patient, you just need to look at the up to rectosigmoid max, right? So you have another option, and it saves a lot of things. You can do it without sedation if you want. If it's a young male and he's okay with it, it takes 5 minutes. Second, please, Paul, Shanil, anybody just jump in here, or any other questions. So blood in stool. Clear, agree. Everybody agreed?
He actually said PR bleeding. He didn't say blood in the stool.
Okay, so PR bleeding. Would it be different? Why would it be different? So what difference does it make if it's mixed in stool? The same patient, 19-year-old, bleeding PR. 19-year-old, blood in stool. No, not the cause. Procedure-wise, do you think there will be a difference in these two? In blood and stool, you would want to do a full colonoscopy. That's what he wants to. Whereas bleeding PR, you would blood mix with stool, if I make it more clear. Or if you see, sometimes patient will say, come and say, we occasionally see clots. You need to do a full colonoscopy. Okay. So blood, got blood. What else? Indication, clear indication, we have no doubt. Weight loss. Weight loss, yeah, if you don't find any other reason. Obviously, weight loss, you need to make sure there are other causes of weight loss. So weight loss without any biochemical, obvious diabetes or thyroid or anything else, and you have somebody who comes in with weight loss where you can't pick up or pinpoint any symptoms, yes, colonoscopy should be done. But what else? Fecal occult blood is positive. Fecal occult blood positivity, would it be different for someone who is 25 with a normal hemoglobin versus somebody who is 55 with an HB of 10? So fecal occult blood, again, depends on why you're doing it. If you do it, a lot of people will be positive, the way we do fecal occult blood. Unless it's done properly.
Sir, I think fecal occult blood is a very weak indicator.
Yeah.
Because most of the patients we do FOB is inpatient. And there are studies which say inpatient FOB is useful. But we tend to do inpatient FOB. The second thing is we tend to look just at the number or at the result of the test. We don't look at the patient. As you said, has he got anemia, has he got any other systemic illness? If it's somebody who's just walking around and we did a FOB and came back positive, am I going to do a colonoscopy? No. I'm going to find out why was it done and was there any associated symptoms or not.
So what he's trying to say is wrong test done for wrong reasons will lead you to wrong decisions. So FOBT is okay if you are screening a certain adult population, okay, and you want to pick up and you want to cut down on the number of colonoscopies and you say we're only going to scope those who are positive, yes, fine. But FOBT done in someone who's got anemia and you're not sure, and you say, well, let's do an occult blood. If they have got positivity, then of course it's a different thing. But like Shanil said, you must know why you're doing occult blood. Occult blood is done when somebody is losing blood and you don't know where blood is going, right? Agree? So you do for the right reason and you will get the right answer. Otherwise, you will end up doing a colonoscopy in someone who doesn't need it. It will be good for your purse, for your bag or wallet, but it's not going to be good for the patient. So weight loss, we agree. As long as we don't find anything else, yes, colonoscopy. Bleeding, yeah. So if somebody comes with melena and the upper GI is normal, then you do a colonoscopy, yes, you do, okay. But there are more common, simple indications which we are not. Abdominal pain, oh, that's interesting. How many, I'll come to you next. Abdominal pain. How many colonoscopies have you done for abdominal pain, or have you seen done for abdominal pain where you have picked up something? Anybody? You do, but you don't find anything. You need to? So irritable bowel syndrome, is it a diagnosis of exclusion? Yeah? So you need to do a colonoscopy to diagnose IBS. If it's normal, then IBS or not? No. That's all. No. IBS is no more a diagnosis of exclusion. No, now you're talking different. Let's focus on abdominal pain. Paul, you want to say something on abdominal pain? So I would echo that. I have, in my 34 years, just abdominal pain as an indication. I don't use that as an indication, but I have seen a lot of those patients who've come to see me with abdominal pain who have had a colonoscopy, and I haven't yet seen anybody. Just abdominal pain, okay? Abdominal pain with change in bowel habits is a different thing. Abdominal pain with severe diarrhea is a different thing. Abdominal pain with blood in the stool is a different thing. But pure, severe abdominal pain, patient going to ER, having pain killers, settling, again having abdominal pain, coming back. I've seen them have endoscopy and colonoscopy. I have yet to see a positive patient with that kind of history. So abdominal pain is okay, I think, if it's accompanied by other symptoms. Agree? Small volume diarrhea. Why not diarrhea? Why do you want to make it complex? I don't know what small volume diarrhea is. Small bowel diarrhea. So how do you find out? I come to you and I say, I'm going to the toilet 8 times a day, doc, I have watery diarrhea. I have large volume diarrhea or small volume diarrhea? Really? Everybody agrees with her? Anyone agrees? Anyone disagrees? Difficult to differentiate. See, the thing is that you're relying on patient's history, right? Paul, you wanted to say something about this? No? Okay. So you're relying on patient's history. Patient is telling you it's large volume. Well, I don't know what large volume is for Sunil and maybe different for me. So either we quantify. Huh? Yeah. And then other thing is that you need to quantify it then. If you're going to divide it, then you need to actually check the volume. Do we ever do that? Have you ever seen anybody quantify? I haven't. Okay. So to me, diarrhea is diarrhea, unless it's white. If it's white, almost white, then you have steatorrhea, right? Then you know that it's unlikely to be that. But otherwise, anybody presenting with diarrhea, which is not responding to standard treatments, which is accompanied, obviously if it's accompanied by blood in stool, if it's accompanied by weight loss, then you will have reasons to do a colonoscopy. So what I'm trying to tell you here, or what we are discussing, is it's not like, these 5 indications and you do colonoscopy. You have to see the patient as a whole. You have to see whether they're having diarrhea. If they're having diarrhea, are they having blood loss? Are they having, do they have anemia? Do they have weight loss? All those things come into play. So you need to look at the whole thing and then decide whether you need to have a colonoscopy. Have any one of you have had a colonoscopy? I know Nasir, you have, and mine. I've had twice. Okay? You've had twice? Once. What was the experience like? So you were out. I had my first one done without anything. Okay? So I had no sedation. And it was maybe a few seconds it was uncomfortable. The only thing bad about colonoscopy was the prep. Prep was difficult, but again, I will share our preps. Paul did my colonoscopy. And we chatted, and I told him he's not a good colonoscopist. So the other thing that indication may, what do we do about age factor and routine screening? Yeah. Chronic constipation, would colonoscopy help you? You said chronic constipation. If you said acute, short history, it's different. But chronic, I'm assuming you're saying, yes, I've been constipated all my life. And I've come to you because now it's getting a little difficult. I've been taking medicines all the time. Depending on the age, you probably would do colonoscopy on this patient, but what is the yield of it? Most likely nothing, except that if he's been taking laxatives, you'll see some hallmarks of that. What about screening colonoscopy? The international recommendations are different based on their own experience, based on their own data they have. I'm not sure we can apply that here. Shanil, Zal, you want to chip in?
So it's like IBD, their recommendations are different. We don't see a lot of IBD. We see a bit more recently, but not that as much as they do. Polyp-wise, they do colonoscopies. They find polyps in almost every second patient. We do colonoscopy, we find a polyp, once a week or something like that.
So I don't know whether we can apply the international standards, but I'll tell you what my practice is. I'm not saying that's correct. Paul, first you go ahead.
I don't think we can. I came here in 2010. I was here for 2 weeks in the first week. I found a child 9 years of age with
Yeah, Neil.
girl with cancer in the sigmoid. So rare in the UK, and I've only come across a couple of cases in the UK, my own practice. So you can't apply the same screening age in this country as what you would do in the UK. So we would say, when you come to 55, you get a flexible sigmoidoscopy regardless, until you're 60. When you're 60, you then qualify for the right test to go off and have the tested for bowel cancer screening appointment. Because in the Western world, in the UK, it is found that the polyp and cancer rate is highly linked to that age range. At the age 17, there is a cut-off, which the over 70s can volunteer back into. I don't think you can apply that over here. You'll miss so many cancers for some reason. And I've seen cancers in your 20s-year-olds, your 30-year-olds. So how can you apply the principles that are applied in the UK? That's my answer.
I have seen in my residency, for some reason CT scan was done and it's reported as a terminal ileum technique was done, procedural technique was done, colonoscopy was done just to exclude if there is something in it, and in most of the cases there was no.
So yeah, but that becomes an indication. If some reason somebody has a CT scan and it shows thickening either in any part of the colon or ileocecal area, especially ileocecal in this part of the world, you want to rule out TB. So that would be an indication, of course. We are not saying, those are the care indications. We wanted to focus on screening. So what is my practice? There are people who come to us saying that, look, my brother had a colonoscopy in UK or US and he was found to have a polyp, and his consultant said, if you have family, then you tell them to have a colonoscopy. So, you do colonoscopy in those. Some people come here with the fear of, just because, they've heard that there's screening, they would do it. I encourage people over 55, not 45. I think 45 is the cutoff internationally. So 45, I don't recommend colonoscopy in Pakistan. I'm not saying I'm right, but I feel that's too young for us and we have no evidence. So above 55, yes. After 50, my threshold is a bit low if somebody understands that there are reasons for us to do it. And so I think, I don't know if it's right or wrong, but we talked about surveillance in ulcerative colitis. Let's just quickly discuss colonoscopy in ulcerative colitis. So you have a patient who comes in with diarrhea and bloody diarrhea, and you diagnose ulcerative colitis, and biopsy is proven. This patient comes back to see you again, now is stable on whatever treatment she or he was started. When would you do a colonoscopy in this patient again? It's a left-sided colon. From transverse further, it's normal. So it's a left-sided colitis. When would you do a colonoscopy on this patient who's now come to see you in your clinic, who's otherwise well now? 8 to 12 years. Okay. And if this patient comes back, everybody agrees? No? What would you do? So, okay, fine. I told you it's left-sided colitis. The patient is now sitting in your clinic. It's completely is well. So what difference does it make? How severe the colitis was? How? Symptomatic. He's sitting in your clinic. I'm telling you, he is well. She is well. I am the patient with colitis. I'm sitting in your clinic. I'm saying, thanks, doc. You saved my life. I was going 10 times a day. Now I'm not going. I'm going once a day. I have no blood. I have no problems. I'm feeling great. And it's left-sided colitis. When would you repeat the colonoscopy? This is the question. Usually after 2 years. And what recommendation, who recommends you do 2 years colonoscopy? Or have you seen that being done? So why did you say 2 years? You must have read somewhere or you must have seen, yeah? Or is it just out of your mind you've said 2 years? No, I don't think that's not how medicine should be practiced. Medicine now is evidence-based. You either know something or you don't know something. And there are societies, there are guidelines that clearly tell you what to do, okay? And in this situation, you are I'm afraid what you need to do, thank you. The point I'm making is that if the patient is well, and Zal, Shanil, and Paul, you can chip in if you don't agree. If you have a patient with colitis who is well, who's got left-sided colitis, there is no need to do a colonoscopy. Probably for the next 10 years, maybe 15 years. Okay? Because the risk of developing anything in the left-sided colitis is less than pancolitis, right? That's why you want to know. So you do not, and I know that there are centers in this country that do colonoscopies every year in patients who've got every 6 months also you have seen, yes. Every 6 months, and these are very, very reputed centers. It's not evidence-based. It is not recommended by any society that I know of in this world. So you must read when to scope.
So
with calprotectin now, this concept of going in and seeing, at least in our part of the world, I feel, is really not necessary. That's now different. If you have, what number of patients are going to have PSC out of colitis? Huh? Yeah, okay, less than, about 10% be le lo, the 1 in 10, right? I don't see 1 in 10. I'll be honest with you. I think it's less in our part of the world.
Yes,
what
sir,
do you
less,
think?
yeah, less than 10%. Sir, the other question is, left-sided colitis, these patients, like your patient, they come in with flare-up. A lot of people just do colonoscopy on every flare-up that they come in with.
That's what I just said. You now have, number one, you have calprotectin, okay? You'll find out. If it goes up, you know it's flare-up. Anyway, you can take the history and you find out. We always treated flare-up clinically, and I still do. You know this patient has got flare-up clearly because he started having the same symptoms. In Pakistan, you want to make sure he's not eaten or she's not eaten outside. Could diarrhea uski wajah se na hua. So you can obviously do a culture, you can do stool diaz, etc. And you can find out. You don't have to do a colonoscopy to find out whether disease is active or not. I think exception would be that you have somebody with no inflammatory markers going up, the symptoms are not settling, okay, and you're not sure. I mean, what the hell is going on? So you want to put a scope just to have a look whether there is active disease there or not. I think we can make an exception there, but otherwise, for ulcerative colitis, doing a colonoscopy every 6 months or every year routinely is totally unnecessary, and it's actually, to me, it's almost criminal. Okay, so we have.
एक वजह से आपने कहा symptoms patient better हो गया, overall the patient symptoms have got better, CRP, every markers have become normal. They still recommend that after 6 months, 3 to 6 months, you should go do the endoscopy and take biopsy because histological remission is there or not. If histological endoscopic wise, because normal patient symptoms are better, but histology still shows there are inflammation. In this patient, you should escalate the treatment because the chances of relapse are more. So we need histological.
Okay, well, let me argue. There is a difference between the colitis that we see and the way our patients behave versus what we saw in UK. And I have the experience of both world. I used to have inflammatory bowel disease clinic. I'm sure Shanil did that. The whole clinic was just colitis. We didn't see anybody else except colitis. So there's a lot of experience because it's a lot more common. In this part of the world, the disease and the remission and the behavior of the patient is different. I would obviously want to know what the basis for that recommendation is, how strong the evidence is, and I'm pretty sure the evidence is going to be not so easy to prove that. Paul, is that? Absolutely. Yeah. If the patient is asymptomatic, how long have they done trials to see that they're relapsing more or less? So if you go and read that, you'll find out that this is probably evidence, both evidence would be weak, recommendation will also be, slightly dicey. And I would not accept that for Pakistan for sure. Unless somebody stood up from any of the top centers and said, look, this is the study we've done. I haven't seen any study done from Pakistan. In fact, nothing good I have seen that has come, that I've seen in colitis. I haven't, have you? So we've almost covered indications, but what is very important is please don't do colonoscopy when it's not indicated. People do die. What is the mortality of colonoscopy? Kitne, what would you say in percentage? Huh? No, 1% would be very high. 3 in 1,000, 0.3? 0.3? No. So what would be the mortality of diagnostic colonoscopy? And in my view, it should be 0. For diagnostic colonoscopy, if somebody dies. So if you think there is a mortality, forget about discomfort. Mortality, agar hai, to severe morbidity in terms of surgery required post-colonoscopy. Should we not be more careful before referring our patients? ये जिम्मेदारी किसके ऊपर आएगी इस डेथ की? गलत इंडिकेशन में पेशेंट की डेथ हो गई, wrong indication, patient dies, who's responsible? Okay, you'll get away here because there is no accountability in this country. But you have to go up. What will you answer there? We all know everything. Everything is written, everything is taught, everything is understood. Do we practice? Every time you recommend a colonoscopy, you stop. Ask yourself again, are we doing it for the right reason? Okay? When I'm doing screening colonoscopies in patients, or if I recommend, I tell them, look, there is no evidence, and I tell them honestly, there is no evidence in Pakistan that we should be doing it. I have no data from Pakistan. But all I know is that most part of the world is actually recommending it early. I'm not sure. Personally, I would delay it. Okay? So it's up to you, but it's not something that's a must. If I want somebody to get a colonoscopy, all I have to say is, you know what? There's a very high chance of you getting cancer. The moment I use the word cancer, you say, okay, yes, sir, do tomorrow, please, not day after, right? So it's the way you tell the patient. So we've done anything else in indication you want to ask? Elderly patient comes with weight loss and anemia. Oh, they're coming with altered bowel habits, and a recent onset of altered bowel habits is an indication. After, anybody who's had recent altered, and it's not because of medicine, somebody's not taking metformin, for example, diabetic coming in because they've started metformin, having diarrhea, that is not change in bowel habit. So once you've ruled things out, and somebody's got change in bowel habit, that is an indication for colonoscopy. Right? Are we good with that? You got 5 minutes? 10 minutes, okay. So the next thing now we want to do is safety, right? What are the things that are important in safety? You want to set up a colonoscopy unit. What are the things that you would want for yourself? अगर आप डिसाइड करो मुझे अपनी कोलोनोस्कोपी करानी है सर, लेकिन पहले आप मुझे अपने यूनिट का बताएं, क्या क्या चीज़ें होंगी? Fire exit is going further down. I'm talking about my procedure. Yeah, so you should have appropriate space allocated for the procedure, number one. And then second thing, appropriate equipment. Yeah, वो अभी हम आ रहे हैं, अभी तो हम सिर्फ जगह पे आ रहे हैं. तो appropriate space, appropriate equipment, ठीक है? Skilled person, backup facility, ठीक है? Backup for what? मैं इन लोगों से पूछे. So you guys are using high doses of midazolam. I asked everybody. The lowest we got was 3 milligram. Okay. There is the higher midazolam you give, and you combine with one of the kins or whatever, the higher the risk of complications. Now we are talking about not procedure. This is pre-procedure complication. So what would you need if you're using this kind of high dose of, firstly we will discuss and we'll show you that this is not appropriate, but when you're using such high dose, what is it that you need? Anesthesia people, okay. If you're lucky, then fine, but most people don't have anesthesia backup. So you need to have resuscitation trolley, okay. What is important to have other than resuscitation trolley if you're having midazolam? If you're giving, yes, flumazolam. So you need to have antidote, okay, and you also need to know how to use it, because you'll not hopefully need it, but when you need it, it will be very rare, and then you'll be thinking what dose you should, so you should be aware of it. Other than that, monitoring of your patient. How do you monitor your patients? So you need to have good monitoring facility, you need to monitor their saturations, you need to monitor their pulse, etc., right? We generally, Paul, I'll leave it to you. Sedation.
You mentioned skilled staff. Who are you talking about?
Good point. What is skilled staff? आपने कहा था.
Skilled staff for that education I will not take, but I will ask people where colonoscopy is done well.
So you're talking about the person who's doing. Yeah, number one. What else?
Plus the department, the person being in the assistant also is important.
Why is he important?
Because in any procedure, gastroenterology assistant is also important.
So, okay. So let me ask you, Paul, you want to add? I just wanted to ask you.
Skilled staff, in my opinion, is the person who's actually there to help support the endoscopist. And I would then emphasise that by saying, who's seen more procedures, you or the skilled staff? So who's seen the complications and risks?
Who's seen more cases, you or your technicians? Technician is seeing everybody's, right? So he's seen complications more, that's the point he's making. So you need to have skilled endoscopists, that's important, but you need to have the skilled support staff, okay? If you want to have a colonoscopy, if I want to have a colonoscopy, I need to know, was the scope properly sterilized? Wouldn't you?
Yes.
That's part of safety. So you need to know the person who's doing that is right. You can do manual, you can do automated system, that's fine. But it should be done appropriately, and this is part of the course. We will actually show you how manually it is done and how we do it in our setup. So, I mean, these are the things I would want to know. That am I going to be monitored well? That the person who's doing has done it and he knows how to do it. That the support staff is there to wash the scopes, to clean the scope, to actually manage and support, right? So all this is part of safety. Sedation, equipment, space, right? Cleaning. All this comes under one thing, and that's patient safety. Patient safety is not just doing a good colonoscopy and finished. Patient safety includes all this, right?
The right team in the room. So
right team in the room.
Person holding,
the right person to actually.
Equipment.
So, person who's supporting you, technical side, nurse or endoscopy tech, should have some experience. Otherwise, if they're absolutely new and they have no idea, then as a doctor you find it difficult, and obviously the patient doesn't know. Patient doesn't know. Patient doesn't know that scope has to be clean in a certain way. He will just simply say, "Safai to theek hoti hai na," right? They push that.
Before starting the procedure, you should know that the tech staff that you have, what abilities do they have. If you have a tech person who's not done used a snare or not done a hot snare before, and you have a polyp, then when you have a polyp you're stuck. So you should know that you're doing this procedure, the person next to you, what skill sets does he have, so that if you need somebody with a higher skill set, so you call them earlier rather than at the middle of the procedure.
So I mean, this is important because you're doing a polypectomy before you know the snare is completely closed, right? And because the tech didn't have any idea, you said close the snare, he closed it. He went all the way, zapped it, right? For smaller polyps that shouldn't be a problem, but larger polyps obviously they would be. So what sedation should be used? Paul, what sedation do you use in your practice?
In teaching it's slightly different. If I've got a trainee, my tolerance for going above what I use is, I do have an allowance. So standard that I would give is 2 milligrams of midazolam maximum to 25 milligrams of methanol equivalent. However, if you ask me how many times I actually administer that, I would actually turn around to you and say, in all my experience, and this is the most important thing you need to do, in your packs, you talk about KPIs and key performance indicators. I can tell you how many procedures I've done, and out of those procedures I've done way back when I started, 78% of it was done without any sedation whatsoever, and any pain whatsoever. So that's 78% of just under 100,000 procedures.
So what he's saying is 2/3 of his patients, more than 2/3, well, 3/4 of his patients are actually done without any sedation. If we are going to use midazolam, then we in our unit would use 1 to 2 milligrams of midazolam. And I give the option to the patients. I mean, in the female patients, our tendency is to give them the option of, if we have the option, then we wouldn't mind using propofol. But we want to make sure that female patients, especially if they're young, should not remember this procedure, should not have a memory. You know why we give midazolam? You keep on increasing midazolam. What is the advantage of giving midazolam? Amnesia. So everything depends on memory, right? If you don't have memory of something, you don't know, right? You may have had, so this concept of दो किन्स और बढ़ा दो, यार पेन हो रहा है उसको जो भी साथ है दो देना किन्स यार, इसको 2 मिडाज़ोलम और दो यार. He's not sleeping. It's not about sleeping. The patient is having pain because you are the one who's causing pain. It's not because आपका sedation काम नहीं कर रहा है. It's not because your KINS is not working. It's because you are. When do you have pain? No, instrument stuck somewhere. Well, I mean, if it's stuck at rectum, would you have pain? So where is it stuck? It's stuck with the loop. Pain comes when you stretch the colon. What are the ways of stretching the colon in colonoscopy? Too much air, good. And something that you've all, well, Paul will share this with you. We don't use the word push. Push means you're advancing against resistance. Should not happen. Advance. No, I know. No, you are right. But what we are saying is we try and discourage in this course के हम push नहीं करेंगे, हम advance करेंगे, ठीक है? जब आप सब ने यहाँ का loop is a problem. Everybody. What does loop do? Pain. Because you're constantly going in and in and in and in, and it's stretching, and hopefully you stop. If you don't, you end up causing major issues, right? So you have pain because of air, excessive insufflation, but mostly pain is because of having more scope than what you should be, which leads to stretching and which causes pain. So if patient is having pain, it's not because midazolam is not working or KINS is not working, it's because you're not working. Sorry, Afzal. So, see, it's a very important point. Before you insert the scope, make sure everything is working. Then we'll cover everything that we have discussed in the course as well, but हमने कहा कि एक general discussion हो जाए. So sedation we've done.
Just one point on sedation. What do you guys feel about? Do you give midazolam first, or do you give KINs first, or do you feel that it doesn't make any difference whatever you give first?
Good point. Why do you give midazolam first? I don't know. No. That's not the reason. Anybody else? आप midazolam पहले क्यों देते? No idea. How much time does midazolam take to effect? To have its effect? 2 to 3 minutes. Okay. Huh? I said 2.5 minutes. Need?
0.01 milligrams per body mass kilogram. That's after the brain diet. Then there's this study which shows that if you give it as a bolus, that double within 30 seconds. So you're actually giving double the amount. So in some practices, you give 1 milligram, and you give it over 30 seconds, it equates to 2 milligrams. If you're putting it in a sequence, you can do a procedure with 1 milligram on the blood pressure. That's where that study came.
So what's the advantage of giving midazolam first? First, Shanil said you give.
Which one do you give first?
Which one do you give first and why? There is a logical reason for what you said. That's what we were asking. Yeah, so there is a reason for that. The effect is, what is it, Shanil?
Paul, we give fentanyl first and midazolam afterwards because.
You should always give the fentanyl first. That's point one. And we'll discuss. And now the discussion, you now know he said give the fentanyl first, then midazolam afterwards. So why do you think you give the fentanyl first? What does fentanyl do? So what does what? What does fentanyl do? Keep it simple. Anything that we do on this course, we'll keep simple. So it helps with pain relief, and also it can make you feel a little bit drowsy. Then, so if you give the maximum dose of midazolam at the beginning, and the most important thing during the colonoscopy is to make it as pain-free as possible to reduce the discomfort. How can you then give them the maximum dose of pain relief if you're compromising that by giving them midazolam first?
So it's to do with the receptors. So you give your KINs or your narcotic or morphine-like substance first, and then give midazolam. And the reason for that is the receptors. So your dose requirement would differ. So you would not require that much, correct?
Yeah.
Okay. So just quickly, last thing, safety. Which is a safer colonoscopy, done under general anesthesia or the one that's done under sedation or without sedation? Right, so why? Absolutely. So patient's pain response tells you, which will obviously disappear. So you can keep going, and the chances, if you're not careful, obviously of complication would be more. So patient stops you, the pain when they have, this stops you. Are we ready? Are we done for time? So we are still left with some things that we'll cover, complications we need to cover later on in between our discussions, we'll have them. And how do we manage complications? And BAL prep. Those 3 or 4 things, you just remind us and we'll cover it. Okay, so Paul, over to you, man.